Hey everyone, hope you're having a great start to the week. Today we're going to talk about HCC. I think HCC is a complicated and such an interesting disease site for several reasons. One, many patients have cirrhosis as an underlying competing risk that can drive their management. Two, you have transplant as a potentially curative treatment option, which you don't have in a lot of other GI disease sites. And then three, there are several non-surgical local therapies. So what I'm going to try to do is to give sort of a 20,000-foot overview of how I think about HCC and then get into some of the treatment details. Let's go ahead and get started. Okay, this is HCC 101. So let's start with diagnosis, as we always do. So different from other GI disease sites, probably most cancer sites, diagnosis in HCC is actually imaging based, and you can use either MR or CT. At our institution, we use dynamic contrast enhanced MR, but acknowledging that that modality may not be available both worldwide, both MR or CT are acceptable, and the LIRADS criteria uses both or either. Pathology is actually not required for diagnosis, though there is a trend to getting tissue, particularly for advanced disease, because that may drive treatment options. Biomarkers, the main one being AFP, is not sufficient in itself to diagnose HCC because about 40% actually have normal AFP, but one should always check an AFP. What are other important labs? So the main ones are bilirubin, albumin, and INR. Those determine the Child-Pugh, and albumin and bilirubin determine the ALBI scores. Child-Pugh also has ascites and encephalopathy. And you also want to get platelets to get a sense of the patient's liver function and related to that, whether or not surgical resection is an option. So what is LIRADS criteria? Two of the strongest features are this non-rim aphy and delayed non-peripheral washout. And I'll talk about those a little bit more in the next slide. LIRADS also takes into account threshold tumor growth, defined as greater than 50% size in the last 6 months or less, but that is actually least predictive. Tumor size is also part of criteria, basically because imaging accuracy is better for larger tumors. So LIRADS goes from 1 through 5. I'll just talk about 3, 4, 5 here. So if a tumor is graded as LIRADS 5, then that is almost definitely HCC, 95 to 99%, and we treat those tumors. LIRADS 4 means about 2/3 are HCC. You can either biopsy to confirm. We tend to do close follow-up. In some scenarios, you may want to treat as well, just depending on the whole context. LIRADS 3, 30% HCC, we generally follow these patients. And then there are two other terms to know about. There's LIRADS M, which means it's most likely cancer, but only 1/3 are HCC. So these you want to biopsy to determine the histology. And then there's LIRADS tumor in vein, which could be HCC, it could be cholangio, it could be MITS. So you want a biopsy here as well to figure out how best to treat these patients. And then the LIRADS diagnostic criteria is here on the table on the left, showing you how you add up the different criteria to get the points to determine the LIRADS score. All right, going into some of the terminology in a little bit more detail. So what is non-rim aphy? This means that the whole lesion, not just the edge or the rim, is bright on an arterial sequence. And of all the timing of arterial sequences, generally late arterial is best. And here is an example, 3 examples of sort of the whole tumor being bright. In contrast, if just the rim or edge enhances, then it could be an alternative histology such as cholangiocarcinoma. So that's non-rim aphy. What about non-peripheral washout? This means that the central part of the tumor becomes darker as compared to normal liver on delayed sequences. Again, not just the rim, but the central part becomes darker. Sometimes you can also see an enhancing capsule. You can see that with the orange arrow here in the corner. And typically a delayed sequence is about 5 minutes after contrast injection. Important to remember that the LIRADS criteria are only validated in populations at high risk for HCC. These are patients with underlying cirrhosis, of course, if they had prior HCC, or if they have hepatitis B but are considered high risk for HCC. In contrast, if you have a patient with congenital vascular cirrhosis or HBV, but low risk, then you can't use the LIRADS criteria. They're not validated. So you got to remember that. All right. HCC is a disease site where there are several treatment guidelines and staging systems, as compared to a lot of other disease sites, which at least in the US are driven by NCCN. And that is probably because traditionally and currently, HCC is largely managed by hepatologists. So a lot of these staging systems are sort of GI and not so much oncology specific backgrounds. BCLC, the Barcelona staging system, I would say is the most commonly used. That being said, I think it's better for prognostication than treatment algorithms. What does BCLC take into account? So the patient's performance status and liver function in addition to the tumor burden. In terms of their treatment recommendations, what they recommend may not reflect your practice or US practice. For example, TACE is first line, not TARE, and they do not include SBRT. There are several other guidelines out there. There's EASL, there's AASLD, there's a PASL Asian guideline, NCCN, of course, and ESMO recently put out guidelines. Basically, every continent country has their own guidelines, and I think it's important to review them to get a sense of sort of what the different practices are, seeing the similarities and differences between the guidelines. All right, I actually want to start by talking about liver transplant. This is sort of something somewhat unique to HCC. As I mentioned, it's high risk, but potentially high reward as well. So why do we even do transplant? What is the rationale? It's to remove both the gross tumor, like you would with other local therapies, but also to correct underlying liver dysfunction by giving new liver. That being said, it is an involved process. There's surgical morbidity, patients can't get immunotherapy, and of course, there's limited organ availability. In the US, prioritization is based on the MELD sodium score. Components include dialysis, creatinine, bilirubin, INR, and sodium. And as you can imagine, priority is given to the sickest patients, those with the highest score. However, patients with diseases like HCC can receive exception points because the MELD sodium score may underestimate their risk of death, meaning a patient with HCC may have a poor prognosis, but their score may be low. But not everyone with HCC qualifies for exception points. To do so, you need to meet the Milan criteria, which we'll talk about, and get through a 6-month wait period without progressing out of eligibility, basically a biologic test of time for that tumor. Milan criteria are 1 tumor, less than 5 centimeters, or 2 to 3, up to 3 centimeters. How many exception points do you get? So generally, you get 3 less than the median MELD at transplant for your specific region. So this depends on where you live. That brings us to 2 other concepts, bridging and downstaging. So bridging therapy is for patients who already meet Milan criteria, but they have to wait that 6-month window. So this is offered to control tumor growth and prevent them from dropping out so they can get transplant. TARE is the most commonly used bridging therapy, but there's also ablation, radiation, TACE. And I'll talk more about these local therapies later. If you don't meet Milan, but are just out of Milan criteria, you can actually try to downstage the tumor so they are within criteria to receive exception points. But to do that, you can't have a huge tumor or be, way out of criteria. You have to meet the UNOS downstaging criteria, and that is less than 8 centimeters, 2 to 3 tumors less than 5. You can have up to 5 tumors, but they have to total be less than 8 centimeters in diameter. With all that being said, because these patients are at risk for developing liver dysfunction with aggressive treatment, generally we limit downstaging bridging therapies to patients with slightly better liver function, Child-Pugh A and B, and with a bilirubin less than 3, generally. Okay, obviously doesn't have to do with HCC, but this presentation may be a little bit long, so just wanted to share these fun photos. I was recently in India, actually came back about 24 hours ago, so that probably explains why there are like bags under my eyes, but we started there to celebrate Holi, which is a festival for the arrival of spring. Dr. Amit Singhal, a world-famous hepatologist, was on our trip, so I just wanted to show this picture. The food in India was absolutely incredible. This is just one of the meals, actually. It was very sad this morning when we woke up and there was no amazing buffet breakfast. Okay, anyway, let's talk about treatment. So I guess I'll preface by saying that treatment in HCC is highly nuanced. I'll give a framework with regards to how to think about all the different options, but it really is case-by-case basis, patient-dependent. which treatment is the best. And this is where I think multi-D discussions really, really come into play. So let's talk about early stage first, and this is based on the Barcelona staging system. This includes very early stage BCLC 0 and then BCLC A. So there are really three main options for these patients: resection, transplant, and other local therapy. These are patients who do not generally get systemic therapy. So when do you do surgical resection? This is generally for patients who have one tumor and do not have underlying cirrhosis, severe cirrhosis. There's actually no restriction on the tumor size as long as a functional liver remnant is sufficient. So even if a patient's tumor is very large, they can still get surgery, presuming they have enough normal liver left, and that's generally 30% versus 40%, depending on if the patient has cirrhosis. Note that there is data, and we do resection if there's more than one tumor. However, the thought is if a patient has more than one tumor, they may have more occult disease, so perhaps transplant is a better option because they're more likely to have recurrence in other parts of the liver. It's transplant, which I just talked about, but this is generally what we recommend for patients who have clinically segment portal hypertension and decompensated cirrhosis, or more than one tumor, with a caveat being what I mentioned above. A tumor must be at least 2 centimeters to get exception points. So they can't be very early stage, they have to be early stage, BCLC-A. Okay, outside of resection and transplant, there are the other local therapies, which again, I'll get into more detail later in this talk. If a tumor is less than 2 centimeters and the patient is potentially a transplant candidate, you can consider waiting so they get to being eligible. That being said, if there are other features that potentially indicate more aggressive disease needing more urgent intervention, such as a high AFP, you may want to treat them then and there and not wait. That's all sort of balancing different competing risks, different potential treatment options, highly nuanced. All right, let's go to intermediate and advanced stage. So what is intermediate stage? Multifocal disease, liver confined, no vascular invasion, or unresectable or beyond Milan. So based on what I just said, you can already tell this is a very heterogeneous group. And what makes it tough is that it's actually probably only comprises 10 to 20% of all HCC, but is a wide range of presentations. So it's really hard to just put them into one bucket. And generally, we think of three paths these patients can go down. One is transplant. If they meet the downstaging criteria, you try to get them to transplant. Two, sort of on the other end, if they have extensive disease, more than 50% liver involvement by lobar, then they go down the systemic path, more like advanced stage. And then the other group is that you may consider what we call destination local therapy, which means local therapy alone if they have sort of well-defined nodules. Again, this is a heterogeneous group. There are emerging data on combination therapies, mostly with immunotherapies, and I think that is probably coming down the line. Stage C is advanced. These patients have vascular invasion, they have extrahepatic spread, but their liver function is still good. These patients get systemic therapy in general. Of course, again, nuance. Some patients with VP1 or VP2, that is a staging system for vascular involvement, which grades it based on how proximal or distal the vascular involvement is. So potentially for more early stage vascular involvement, some people are considering more aggressive local therapy, but that's a little bit in the weeds. But generally, stage C, advanced systemic therapy. What do you need to know about systemic? So this is very basic, mostly for the non-medical oncologists, but this is how I think of it. First line is IO-based atezo-bev based on Brave 150 or durvalumab based on STRIDE. Both are first line, but in patients with a BEV contraindication, which is mostly high risk for bleeding, they get STRIDE. Lenvima over sorafenib is another option for patients who cannot get immunotherapy. Mainly this is patients who've had transplant or if they have autoimmune disease that is severe, not just any autoimmune disease. Second line, Lenvima over sorafenib if they've had IO already, or ipi-nivo. There are other second line options, TKIs, cabo, rego, ramucirumab based on their AFP, which I'm not going to get into details of because I don't know all the nuances of that, but those are the second line options. Systemic therapy is evolving. There are many more options and probably new things coming down the line as well. Okay. Let's talk about local therapies. Complicated topic. for several reasons. Practices are highly institutional dependent. There's really not a lot of randomized data comparing the different options. So I will provide my framework for how I think about the different local options and how I think of recommending one over another. So let's start with ablation because in some ways that may be the most straightforward. There's cryo, there's RFA. We use microwave ablation the most. The control rate is high for smaller tumors. That's generally less than 3 centimeters. These patients have to get general anesthesia. So this is a larger procedure than really the other local therapies. The main limitation are patients who can't get ablation is percutaneous access, the location of the tumor. So tumors in the dome, near the diaphragm, near the bile duct due to risk of infection, and then subcapsular tumors due to risk of rupture or bleeding are ones where ablation is probably not a good treatment option. So let's talk about TARE or Y90 or red seg or CERT, though CERT is apparently a trade name. All 4 of those refer to the same treatment. And if you want more detail on this, feel free to listen to my interview with Dr. Riyad Salem, where he goes over a lot about these procedures, and I personally found it very helpful. But just to give some background, Y90 traditionally was actually used in the palliative setting. It was done for the whole lobe. Obviously, the dose had to be lower. Now we only use whole lobar treatment if we're trying to achieve contralateral liver hypertrophy. Otherwise, TARE, Y90, is used for potentially curative treatment, and it's a lot more selective. Currently in the US, this is the most used non-surgical therapy for bridging down staging. So I really think it's important for not just IR doctors, but radiation doctors, anyone treating liver cancer to at least understand the basics of Y90. Constant sedation is required, and feasibility is all based on a mapping angiogram. Where is the blood supply going? So excessive shunting to the lung, to the brain, to any other normal organs is the major contraindication. That being said, other less favorable scenarios would be potentially a tumor that traverses multiple segments, but in each segment, there's a lot of uninvolved liver. So because by definition, the whole segment has to be treated, if only a small part of that is liver, then proportionally more non-involved liver, more normal tissue would be treated. A counter argument to that is patient getting surgery, then the whole segment would probably be taken out anyway. Conversely, if you have a tumor that is widespread, multifocal in one segment, then Y90 may be a better treatment than other local therapies like SBRT or SABR, precisely because treatment involves but is limited to the entire segment. That's kind of how to think about selecting between Y90 versus SBRT. Let's talk about dosimetry. So the 2 main ways that dosimetry is conceptualized with Y90 is standard versus personalized. So standard is a historic method where everything was thought of as a single compartment, whether it's tumor, whether it's normal tissue, all one of the same. And that is the traditional MERD model. In contrast, with personalized dosimetry, it's multi-compartment. So you treat the tumor, the liver, and other tissues separately. Your dosing is more intentional, and you can quantify the dose to the tumor versus normal parenchyma. As you can imagine, that is better for larger tumors because you want to spare normal liver and also tumors with portal vein thrombosis. To me, a limitation of TARE is that although there's a trend reporting post-treatment dosimetry, this is not standard and not required, and often not covered by insurance. So you really can't always precisely gauge where and how much dose is deposited. I feel like my lighting is weird and there's light coming through, so I'm just gonna rotate a little bit. Sorry about that. Okay, sorry. Okay. All right, let's talk about TACE. So in the US, it's been mostly replaced by TARE, but globally, it is actually still the most commonly used therapy, and it's in the BCLC system. But why has it been replaced by TARE in the US? 2 main reasons. 1, it's more toxic. And then 2, the duration of response is shorter than TARE. So while each treatment is cheaper, and that may be why it's used more globally, if you need more treatments over your disease course, then the lifetime cost will be more. And of course, that is institution dependent. There are many factors that affect how many treatments you need and the cost, but that's generally the comparison. However, many recently completed and ongoing studies are still taste-based. So you need to know about it. And I think a very valid question, which we think about with these studies, is can we extrapolate those results to other local therapies, TARE, SBRT? And I think the jury's still out. That being said, there still is a role for TACE in 2025, and a couple of scenarios to consider it are if the TARE study demonstrates significant shunting. Since DEB taste beads are larger, shunting is less of an issue, so that is a scenario where if you had a TACE and TARE, one might choose TACE. Also, if a patient is going to transplant very soon, some folks prefer TACE because then you don't need to worry about operating on irradiated liver. You just get them to TACE and then they get transplant. All right, let's talk about SBRT and SABR. This is obviously what I do, so I'll talk a lot more about this in the last part of this talk, but just want to put in a couple key points with the other local therapies. So there is ablative potential, and based on the studies, I think there is better data for it, or there is, I think, robust data for larger tumors and tumors with vascular invasion. A relative contraindication is with tumors near the stomach and bowel. That being said, you can dose reduce near those structures. And HCC is radiosensitive. So, I think by dose reducing at the interface between the tumor and the stomach or the bowel, you're still able to treat and get good local control. And also there are new technologies such as adaptive radiation, MRI radiation that can make the treatment more precise and decrease the treatment margins. I will acknowledge that SBRT and SABR is inconsistently included in practice guidelines and staging systems, but fingers crossed that changes sometime in the near future. All right, let's take another break because there's a couple more slides. So this, obviously, I'm in front of the Taj Mahal. We did a sunrise tour, absolutely stunning. Next, we went to Jaipur and we got to ride elephants. These are like the sweetest animals. They were talking to each other here. I got to pet their trunk. I mean, they were just incredible creatures. And then last part, we went to Ranthambore. Sorry, I might have spelled the name of that city wrong, and did a tiger safari. This is Priya. She is only 23 months. She was following us in our safari vehicle. Just incredible to see all these animals in the wild. Okay. Last couple slides are sort of more radiation specific. So if you're a non-rad onc, you can feel free to tune out, or if you want to learn more about radiation, feel free to listen in. So here are the trials I think you should know. So the first is RTOG 1112. This is an NRG trial, PI, the incredible Laura Dawson. This was a phase 3 randomized trial of sorafenib with or without SBRT for unresectable HCC. The median tumor size was 8 centimeters and 74% had vascular invasion. Hence what I said earlier about data for SBRT in these larger tumors with vascular involvement. The addition of SBRT improved PFS. There was a trend to improve OS, 12.3 versus 15.8 months. The P was 0.06, one-sided. That's a primary endpoint. The main limitation, of course, is that sorafenib is no longer the standard of care. I think you should know this palliative study run by the Canadian Cooperative Group. This was a randomized trial of patients with painful liver tumors, either HCC or METs. They were randomized to just one dose of palliative, essentially whole liver radiation, ACRE times 1, or best supportive care. And radiation improved pain at 1 month for a large portion of these patients. These are patients who may have narcotic refractory pain that is really detrimental to their quality of life. So this is really just a plug to remember that radiation can really improve, can help improve symptoms for these patients. Okay. A trial came out in the JCO last year, 2024, ended up being actually a big year for radiation, liver radiation studies. So this was SBRT versus RFA. In patients with less than 5 centimeter tumors that were recurrent. Sorry, lighting is like really weird again. Okay. Okay, I think it's okay. SBRT had better local progression-free survival with 93% at 2 years. No difference in PFS or OS, not particularly surprising with a local therapy. The main limitations are that microwave ablation is now more frequently used in RFA, and some of the tumors were on the larger end of what one might treat with ablation. But I think even barring a comparison with RFA, you can see that the local outcomes with SBRT very high, 2-year, 93%. This is a good outcome, and toxicity, which I didn't put here, was low. I want to put a plug in for NRGGI 012. This is not yet opening later this year. The PI is one of my colleagues, my prior attending, Jen Wu at MGH. This is a phase 3 randomized trial comparing atezo-bev or STRIDE, the current standard of care, plus minus SBRT for unresectable HCC with vascular invasion. Primary endpoint OS. So I encourage you to open this study. Hopefully it'll accrue quickly, and we can hopefully establish the role of SBRT combined with IO-based therapies for advanced HCC. All right. Whew. Take a deep breath. Okay, last slide, radiation details. So first, who to treat, who not to treat. I limit my treatment to patients with Child-Pugh A, B7, and select B8. What do I mean select? If that B8 is driven by ascites or encephalopathy, I tend to be wary to not give radiation because there is, first of all, their mortality is high, and also radiation could potentially tip them over with regards to liver dysfunction. How do we measure radiation toxicity? We generally think of the main toxicity being non-classic RILD, radiation-induced liver disease, which is defined as a post-treatment increase in Child-Pugh score by at least 2 points. What about protons? You'll probably be asked about this. So the potential benefit for protons is due to decrease in dose to non-target liver, mitigating the likelihood of liver decompensation. This is shown in retrospective data. There is a prospective phase 3 randomized trial that hopefully will answer that question definitively with a primary endpoint of OS. That being said, when people ask about protons, I always sort of mention this as one tool in our toolbox as radiation doctors. We also have MR-guided radiation, adaptive radiation, which can make the treatment more precise as well. How do we sim these patients? You always want to give IV contrast, 4D CT, motion management, NPO if the tumor is near the bowel of their stomach, triple phase scans to see where you can best see the tumor. We treat with MRI-guided adaptive radiation, but I should have put here that if you're treating with CT base, you really want to consider fiducials unless there is a really good anatomic landmark that you can align to day to day. You want to contour on the ITV. I generally add a 5 millimeter margin for PTV depending on my confidence in the immobilization. Dosing. Many dosing options, there's several dosing options, not randomized data comparing them. There's 48 gray and 3, 40 and 5, 67.5 and 15. Remember that HCC is radiosensitive. Generally, we consider a greater number of fractions for patients with potentially more compromised liver function and if the tumor is near a radiosensitive structure. I also want to note that in cases where the patient is pre-transplant and where there might be a concern that high dose to vascular structures can cause complications like stricture, some institutions, not all, will decrease the pre-op dose to 35 to 40 gray and limit hotspots to the vascular structures. There's not randomized data suggesting that or even really large series, but definitely anecdotal evidence of issues at time of transplant when you get a lot of dose to those major vascular structures that you need for the anastomoses. Lastly, OAR is the main one, is a 700 cc metric. You might ask where it's from. So this is just based on estimating that a small adult male liver is 2100 cc's, and this is a third. So kind of a crude estimate. You might think that the 700 cc's should change depending on obviously the size of the liver and the functionality. But in practice, in 2025, 700 cc's is what we have. Hopefully in the future, there'll be more personalized sort of functional imaging, functional definitions of OARs and constraints. Whew, okay, that is all I have for HCC. Obviously, much more I could say with regards to each of those topics. Hopefully that was helpful to kind of give a broad overview. As always, happy to take any feedback on this. Just let me know, leave a comment, send me an email, and hope everyone has a great rest of the week. Thank you.